Welcome and thank you for joining us today. This is our webinar series called The Sight and Sound Bites. It's brought to you by the Eye and Ear Foundation. My name is Craig Smith and I'm a development officer here with the foundation. This bi-weekly webinar series highlights research in the two world-renowned departments of ophthalmology and otolaryngology at the University of Pittsburgh School of Medicine. This research is only possible thanks to generous philanthropic support, so thank you to all who have supported our mission so far. I want to go over a few housekeeping things for today. For these webinars, we disable the chat function. However, you can still submit questions for the presenters through the Q&A feature. After the presentation, we will answer those questions for you. We do ask that you refrain from asking very personal questions that may not be relevant to the broader audience. However, we will try to answer those questions offline and get back to you. So please feel free to email any personal questions that may not be relevant to the program at large to me, which my email is just craig@eyeandear.org, all spelled out. We have also enabled captioning for the program today, so please feel free to use the subtitles as you follow along throughout the program. And we'll also be recording this webinar and adding it to our website and our YouTube page. So if you're not able to view it all or at all today, or if you'd like to share it with other friends and family, please feel free to utilize that link later on. Additionally, all of you who are attending today will be added to our mailing list if you're not already on, so you can receive periodic updates on various research taking place within the two departments through our blogs, newsletters, and future webinars. Today's presentation is titled, Taking the First Step, Improving Access to Care in Ophthalmology. Very happy to be joined by some of our esteemed faculty and staff members in the department. We have Dr. Jake Waxman, who's a professor of ophthalmology, Dr. Andrew Williams, an assistant professor of ophthalmology, Sabrina Mukhtar, assistant professor of ophthalmology, Dana McGinnis-Thomas, who's a patient navigator for the department. And additionally, during the Q&A session, we'll be joined by Katie Ciccone, who is a community service program coordinator for the Department of Ophthalmology. At this time, I'd like to turn it over to Dr. Williams to kick off our program. Thank you.
Thank you, Craig. Thanks for the introduction. And as Craig mentioned, we're all kind of excited to come together and talk to you about programs that we're doing here in the Department of Ophthalmology to tackle this issue of access to care and how we're taking one step at a time to understand the problem and to really address the needs of our community. We're going to break it up between us and we're going to talk about these objectives, understanding first, what does it mean to have access to care and what can we do about it? And then looking into what the barriers to care might be and what some of the social factors or social determinants of health are that influence ability to proceed with access to care and how those influence barriers patients face. And we'll talk about then more specifically what we're doing as a department as far as our outreach programs and future initiatives we're looking into. So really getting at the heart of the problem of access to care, understanding the barriers and social factors, and then leading into what we can do about it and actions we've been taking as a department. So access to care as sort of an academic definition of the timely use of personal health services. Really, it's the ability to see a doctor when you need one. And breaking down the problem of being able to get to appointments, particularly in eye care, but in general, it depends on factors both at the individual level and at the larger environmental level. So at the individual level, things like income, education, disability, even things like trust in the healthcare system affect the ability of folks to connect in and follow through with appointments. But also the environment, where are the hospitals located, where are the offices, where are the providers, are those really in a location that's accessible for folks? So the sort of categories of understanding the problem of access to care and understanding what it really means to have access to eye care providers. When we think about wanting to improve that access to care, we think of what gets in the way. What are the obstacles folks face before they're able to proceed and connect with physicians for their needs? So what are their barriers to care? And we know that barriers to care are different for different folks. So different communities face different issues. And we know it's important to get into these communities and ask people about the barriers they're facing so we can think about how to address them and reduce those and improve access to eye care providers to get folks the care they need. One thing that I'll talk about as a point today is these barriers to care are really intertwined closely with folks' social circumstances, the social determinants of health. We're going to talk a bit about what those social determinants of health are and what that means and how these affect health and vision care. So all these aspects, all related to access to eye care, where folks live and what barriers they face. And getting into that, kind of the crux of the barriers or the social factors that influence care have really come together as a concept over the last 20 years or so about social determinants of health, not only the medical determinants of health, what diagnoses, what diseases people have, but what are the social circumstances that are keeping folks from living the fullest and healthiest lives they can. And broadly defined as the conditions and the environments where people are, where they live, where you work, where you learn, where you play. So where folks are in the community plays a big role in how well they're able to receive access to care and continue on a treatment plan with physicians. So broadly, about 5 categories of social determinants of health have been delineated by the CDC, and things like education and health literacy play a big role in the ability to interact with the healthcare system. And of course, the healthcare access, the main point we're talking about today, and getting into other things of social community and context where people live, of course, plays a big role in their access to care. And economic stability, people's income and job security, renting versus owning a house plays a role in how folks' circumstances are and their ability to engage with the healthcare system. And things like food security and utilities, being on and people feeling secure at home. These are very important foundational factors for folks to have in place in order to live healthy lives and access general and specialty care. And looking into all these categories of factors, we know that each one plays a role both in terms of visual impairment and in access to eye care. And each one of these sort of 5 categories of factors is very important to address and to understand. And so kind of talking broadly about these social determinants of health, we want to know, how can we help folks in our community, in the greater Pittsburgh area, understanding what their social determinants of health are, what barriers are faced, and how can we connect them with resources? We'll go into some of the details of this particular outreach program shortly, but we went out, we had a large vision screening event for folks in our community where we opened the Lawrence Convention Center to have eye exams and other healthcare needs. And patients came, got an eye exam and a glasses check all in one place. What we wanted to know, getting to this question about barriers to care, is why did folks attend that day? What keeps people from being able to attend regular doctor appointments in management of eye diseases? And so we had a survey at this large screening event to say, what barriers do you face when seeing an eye doctor? 3/4 of all attendees had at least one barrier, which isn't a surprise given that it might be a very vulnerable population to attend a free vision screening event. By and large, medical costs and insurance were the most commonly cited issues, but also things like navigating the healthcare system. It's not easy, especially if English isn't your first language, or if you're not at a home that has internet connection, or if there's factors that just really prevent that communication with the healthcare system and navigating appointments. Transportation came up, and just accessibility of providers for folks in their neighborhoods. What I liked about this study is we really engage with the patients we want to help, folks who are seeking free vision care because of difficulty accessing the system. And we're learning more on a granular level of detail what barriers they face in achieving care, which helps us to sort of take a step back and say, what can we do as a department? What can we do as a group of motivated people wanting to help folks to really reduce these barriers to care? And it really shows that getting out into the community and connecting folks with insurance would play an important first step. One thing that I thought was important, and one thing our group recently published on, was thinking about these social determinants of health, these barriers to care, and giving a framework to think not only how to understand their effects on eye health, but also thinking what we can do about it. And there's a lot of good research that we summarized to show that, yes, all of these factors, these barriers to care, these social circumstances, they all play an important role in how well people can see and how well people can see eye doctors. But what can we as providers, as an academic ophthalmology department, do to help people in need? And one thing that really struck me was this framework you see here on the screen about bringing the awareness of these social issues and building on that to help folks by connecting them with resources and by adjusting our practice to give care to people. What I mean by that is And you see in the center of this rectangle, awareness, meaning at the heart of all of this is asking folks and becoming aware of their social needs, becoming aware that people have problems with transportation. For patients who we're seeing who have difficulty with costs or have financial issues that may make them lost to follow up later, we want to screen and ask for these things. Ask the question and put this as part of the conversation. Access to care is more than just appointment slots and putting people in them. It's really understanding all the individual social factors and barriers that folks face in maintaining those appointments. So the important kind of cornerstone of all this was increasing awareness of social determinants of health and barriers to care. And then from there, you can see kind of in the upper right, assistance or connecting folks with resources, adjustment or altering the care we provide in a way that's sensitive to the needs of the community. So for example, making sure written education materials are written at a accessible health literacy level for folks who may be low in health literacy or have English as a second language, sort of adjusting and being conscious of how we're delivering care in the community. And the kind of final 2 points are aligning our initiatives with other organizations in the community. There's a lot of folks who want to do a lot of good, and let's see how we can work together to align our initiatives and help as many folks as possible. And then lastly, advocating at the local and state and national levels to help deliver eye care needs to communities. So taking a step back, I really sort of thought this was an important approach because we talk a lot about describing the extent of the problem of barriers to care and access to care, but to really have a framework to think of solutions is something that I found helpful as we've talked about initiatives that we're doing as a department, and I think could potentially be a roadmap for other departments and other specialties too. I'll spend a little time going through a couple of these factors, and then we'll have others on the call talk about their work and how this aligns in this framework. I move the boxes up to the upper right here, and you'll see we're going to start with that awareness, that sort of cornerstone of all this, of asking folks about barriers to care and needs they face. One thing that's pretty unique and a powerful tool at UPMC is the use of an electronic record that goes across all specialties in all offices. What that means is if people are screened for social factors, barriers to care in one location, it'll show up everywhere. And we know that primary care doctors are already doing this. They're asking a screening questionnaire about transportation needs, housing stability, food stability, these sort of important fundamental questions. And we wanted to contribute to that as well. And so we adapted the same questionnaire used in primary care, and we give it to all eye patients. We offer all patients at UPMC Eye Center the opportunity to fill the screening survey. This way we can capture any needs that may not otherwise have been talked about. So if folks have troubles with transportation, this may be an opportunity for that to be triggered, increase awareness about that problem, and allow us to act on it and do something to help people. Really bringing these social factors into the conversation is a critical first step. And as you can tell from the Eye and Ear Foundation hosting this webinar, I think it really goes a long way to show how this is a priority for the department, I think for the community at large. Once we have the awareness, we go over to sort of this assistance model or connecting folks with resources in the community. There are a lot of resources out there, and it's not always easy to know which resource may go best with each patient, and certainly not easy for patients to navigate that on their own, to know what benefits they may be eligible for, what local or state program may connect them with transportation based on their insurance type and income requirements. There's a lot of stuff out there, and it's kind of complicated for folks. One thing that's been a tremendous resource to help address that problem has been hiring a patient navigator, somebody who specializes to be a liaison between the patient, providers, and community resources. And a patient navigator can help to know, based on this patient's needs and this patient's insurance or income or things, they would qualify for this financial assistance program, or they could have this insurance benefit that they're underutilizing. And this really helps to assist folks after making aware of their needs, assist by connecting them with community resources. And we have been so fortunate in our department to have our own patient navigator in ophthalmology here with Dana McGinnis-Thomas, who's on the call with us and will take over here shortly. She's just an excellent resource to fill this very role for our patients who seek care and have other social needs too. We kind of briefly did a quick analysis on some of the work that she's been doing over about a quarter. and found, she receives a lot of referrals. So she's juggling a lot of balls, but she really does a good job with it, finding that 98% of patients who were referred to her had an intervention of some kind, and she resolves most issues, connecting folks with transportation, helping folks get signed up for insurance and financial assistance, even things like helping people get the lights turned back on at home using programs through utility companies. It's just been really awesome. And I'm actually going to turn it over to her now to talk a little bit more about her work and all the incredible work she's doing for us.
Thank you, Dr. Williams. So as a patient navigator here in the department, I do have a unique role in the patient's care. I receive a lot of referrals from the Eye and Ear Institute, all of our satellite offices, our front desk staff, our low vision care team, Guerilla Eye Service, Birmingham Clinic, Catholic Charities, and Katie, who is our community service program coordinator. So all of these people identify a barrier to care or a challenge a patient is having, and they're referred to me. Sometimes the patients that I come across, I meet them face to face. If the patient has already left the office for the day, then I follow up with them in about 1 to 2 days. And I discuss their barriers and we work with them to find the best solution for their situation. So in my role as a patient navigator, it does require creative thinking along with a lot of problem solving to find those appropriate resources that will best meet the patient's need. So one example I have of that, I have a patient who has stage 4 lung cancer, and it was in the summertime. He was having very hard time breathing, but his window air conditioner was in the basement. He could not physically get that air conditioner up the steps and get installed in his window. So I did reach out to the Boy Scouts in his area, and they were so pleased to be able to help him. And they also made it a part of their community service project. And then some other items that I help patients facilitate, enrolling in healthcare coverage. Sometimes they come to our office without a primary care doctor. So I help them and guide them through that process of getting that initial appointment for them. And then other areas include setting them up if they are on Medicaid. Some patients are not aware that they have the medical assistance transportation program benefit at no charge to them. Some patients will be enrolled in Access. Sometimes I help with utility assistance such as LIHEAP, the CAP program, which is the customer assistance program, and the Dollar Energy Fund when patients are having trouble paying their utility bills. Some of our patients look for housing, so I help them with housing applications. And then some of our patients need help with childcare. And that's sometimes the reason that they miss appointments, because sometimes these appointments can be 2 hours, 2.5 hours, just depending on what they're having done. So I do make that referral to Jeremiah's Place. Jeremiah's Place will not ask any questions as long as the child has all of their vaccinations. The child can come in for the day, the night, whatever is needed. Or sometimes if the parent just needs a break. And then also the patient navigator position always requires following up with that patient, making sure if I give them that resource, that they actually made contact with that resource. And then if I send a referral to, say, the Area Agency on Aging, I always follow up with the Area Agency on Aging just to make sure that fax was received and a case manager has that case, just so we have follow through. And then also I work closely with the Eye Center team when a patient is identified as having missed appointments or no shows. So I have a lot of different strategies that I use to help these patients. I call patients sometimes 1 to 2 days prior to their appointment, just to make sure they have everything set up, that they're reminded of that appointment, and they have transportation in place. Sometimes patients require me to call them the morning of that appointment, just to make sure that they are outside when their ride comes. And then once they're dropped off at the eye center, the cab service or access will not come on where we're at on Lothrop Street. So they're dropped off at the Presbyterian Emergency Department entrance. So at times I have met patients at the main entrance so I can help them navigate through the hospital to make sure they get here, because it requires 2 elevators and a lot of hallways. So it can be challenging for them. So this is only a small piece of my everyday responsibilities, but I do believe that building trusting relationships with the patient and community partners is critical to successful patient navigation. And if patients do not trust who's assisting them, then they may not disclose their barriers or accept the help that is much needed.
Thank you so much, Dana. You really do a ton for our patients. And it's just, you know, I always learn more about the things you find for folks and the resources you connect them with.
Yeah, it's a little different every day. Sometimes they'll come to me with, hey, I need a birth certificate or a death certificate for my spouse. And okay.
I feel like some of these sound like my patients I've sent you. So thank you.
There's a few from you.
Yeah. Well, I'll get into our you know, we've talked a lot about these sort of individual level interventions we're doing for folks, and I'll get here shortly to Dr. Waxman and team and talking about the community interventions. Just thinking about our framework, we're talking awareness, assistance with Dana, adjustments, the last individual level sort of category, and this is things like writing with attention to low health literacy levels, and even things like offering telemedicine appointments to make visits more accessible. This was especially important at the early peak of COVID, when folks were a little bit more afraid to leave home, and we were able to help accommodate their needs through telemedicine visits, and their satisfaction rates from this was quite high. And a lot of folks really had interest in continuing doing telemedicine. And our department does still continue this for certain types of patients. So really kind of helping folks at the individual level through assisting with programs and making care more to them. Turning now to the community level interventions of alignment and advocacy, I want to advance the slide and hand it over to Dr. Waxman and company to talk about some of the outreach initiatives that he's been leading for some time to really help deliver eye care in the community.
Hi, everyone. Thanks for spending lunch with us. I'm meant to tell you about what we're doing for outreach right now. Our longest standing project has been the Guerilla Eye Service, our sort of tongue-in-cheek commando eye squad. I can't believe we started this in 2006. It makes me feel very, very old. But basically, we take equipment, medical students, residents, ophthalmology attendings out to primary care sites where people are getting their primary care for free. And we become their eye doctors at that site. We know that all the barriers to care that Dr. Williams outlined, the financial ones, some of the things he didn't mention, the time of day sort of thing, transportation, and frankly, trust get in the way of people coming in to see the eye doc. And so by seeing folks where they're used to getting seen for free, mostly after hours, we're able to reach people that we wouldn't otherwise reach. This is a different model than many other programs that might be similar. We don't do screenings at these events. We do full front to back eye exams. And so patients get refracted for glasses. They get, they're not just their pressure checked, but they get a dilated exam. If they need glasses, we prescribe them. If they need to go on a glaucoma medication, we start it for them. It's been a marvelous thing for a long time. It helps us to reach the people who need to be reached. As importantly, it gives the medical students and residents service education. It gives them an idea of, you know, what it could be like to continue to practice pro bono when they finish up residency. And it's been a wonderful antidote to cynicism for our attendings. You know, when you come to work and you work in the electronic health record all day and you're worried about established level 4s and meeting all the criteria for, you get feedback from the billing people that you didn't code this right. It's easy to get a little disillusioned and start to forget what it's all about. And when you go off to the Guerilla eye service, even when you're doing this simple thing like getting glasses for a kid who needs them for school, it makes a big difference. This is a slide based on a paper we published back in 2019. 360 patients who were seen at mostly the Birmingham Eye Clinic and the Squirrel Hill Health Center. And the glasses we prescribed we do have a focus on making sure that diabetic patients get their annual exams, and we pick up quite a bit of undiagnosed and untreated diabetic retinopathy. And a fair number of people do need more than we can provide on site. And the wonderful thing is that UPMC and UPMC Eye Center agreed way back in 2006 that patients who need things in the eye center can get that without cost. And it's been a marvelous, marvelous thing. We've been doing Guerilla Eye Service since about 2006. And it was 2 years plus ago that Dr. Sahel was approached by the Mission of Mercy dental folks. They have been in Pittsburgh once a year for 5 or 6 years now, putting together an event either at the arena or the convention center where they'll field 100 dental chairs and see thousands of patients for free dental care. This is the second year that the Eye Center participated. We fielded 12 refraction stations, 92 volunteers, saw over 700 patients, and prescribed, more than 650 pairs of eyeglasses for adults and kids. It was exhausting. It was exhilarating. And just seeing everybody come together and really work together. In addition to prescribing eyeglasses, we had a number of people we identified as needing more than we could provide on site. They needed more than just glasses. And so we were able to get them, again, free eye exams back at the Eye Center. If I could say one more thing about GES and Mission of Mercy, it's that this has really become baked in to the Department of Ophthalmology. It's become an essential part of the culture of Dr. Jose Sahel's Department of Ophthalmology. And he stepped up to the plate in ways that you cannot imagine happening in other departments, in ophthalmology or otherwise. Bringing Dana on to make sure that people we identify at GES have the resources we need. Recently, we've hired Katie Ciccone to facilitate the missions, to make sure the medical students don't run out of control, to make sure that patients who need follow-up after GES get called once, twice, 4 times, so that we actually get things done. And this has just made all the difference in the world in making these missions work. Okay, Andrew, you can have it back now.
Off to Sabrina, actually. So Dr. Mukhtar, I think we'll take it from here.
Hi. So just like Dr. Waxman said, having community outreach, aligning with our communities has been ingrained. A lot of us trained here, and it's been throughout our training, and to see the efforts kind of being consolidated and moving into like a wider realm in our department is very, very exciting. And it kind of sets us up to the next step, what's in the future, and that's advocacy. It's really important for us to advocate for our patients. Dana does it on a day-to-day basis. Katie is doing it for our GES patients, but we need to kind of go to our local and state levels now to allow change on a larger level. But before doing so, and where we are right now is we're still trying to understand the needs of our community. We're trying to build partnerships. It's really important to have community buy-in. And so that's just something that, hopefully when we do one of these again, you're going to see an update of what we're doing to advocate for our patients on a policy level. And we're really excited about our future initiatives. We have a lot going on. We truly believe in building an integrative eye center. We're working again with Dana and Katie, trying to listen to our communities and figure out what we need to do to provide them the best care, to get them access to care. But as we're starting to understand issues with access to care, we're truly understanding that there's issues with follow through. And like Dr. Williams said, closely tied in with social determinants of health. One of those things is education. And so we're actually working to get a patient counselor who will work to help educate our patients with certain diagnoses, provide them kind of coping mechanisms, truly help them understand their disease process, and hopefully help them with their compliance. We're working on a larger organization level to partner to address the food security and transportation barriers. For example, a patient with diabetic retinopathy, if they're living in a food desert, that's not, we can tell them in the office, you need to eat better, but how do they do that? So working with them on a more granular level. It's imperative, like I mentioned, to have community partnership and community buy-in. So we're working, it's been something that we've trying to build with community health workers, and we're going to try to really have buy-in from our stakeholders so that we can build this community together, so we can address the issues of the community together. And it's not only the eye center, it's Pittsburgh, it's where we are, especially with our New Vision Institute as well. And in order to get our efforts kind of in a more objective manner and to advocate for ourselves on a policy level, it's really important for us to continue to measure our outcomes. And so that hopefully you'll see with the continued research that we do as well. So we're really excited for the future of our projects, and we've just begun to scratch the surface. And we know we have a lot of work left to do for us. And so we're hoping to continue to build partnerships in the community, continuing to hear from patients so we can figure out how we can best make an impact.
Well, thank you all so much for the presentation. We already have several questions in, and we'll get right to those. And again, for all of our audience members, if you have any questions that you'd like to ask our presenters, please feel free to send them in using the Q&A function. So the first question is, what obstacles do you see to improving and expanding your efforts in the community? And maybe given your background, GES, Dr. Waxman, maybe you could take that first question.
Oh, Craig, thanks for the question. There are two big things I see as, the things that that need to be solved as we move forward. One, and it's been alluded to in some of our discussions today, and really alluded to in our title today, right? Access, first step, right? What we've recognized as we've worked to getting access is we don't always get follow through. We'll do a screening and we don't always get the patient back in when we found something. We'll see a patient in clinic and we'll diagnose them with something that they need follow-up for and not see them again. And the work that Dana is doing and the work that Katie is doing to help people overcome the barriers to this are critical. But the fact is, we still don't really understand every reason that people don't come back. And the work that Dr. Williams and Dr. Mukhtar are going to do on this, the work with the School of Public Health in understanding barriers to follow through is going to be critical if we're going to actually save vision. So I'm going to take the liberty of adding a second one. Our other big obstacle, we're doing about 3 GES missions a month, usually. And thanks to Katie and thanks to the endless energy of the medical students, they want to do more. We've got like 6 or 7 events planned in the next 2 weeks. All of this work is done after hours, volunteer time. And I can't tell you how good it feels to do the volunteer work and how good it feels to see the medical students and residents do the volunteer work. But at some point, we run out of the ability to recruit more residents and more medical students and more attendings to do after hours volunteer work. And we need to start thinking creatively about how we might be able to free up residents and attendings to do some community service work during business hours, to do community service work as part of their job. And we've had some good discussions about this. You might imagine what the barriers to getting this done would be, but this is where I think we need to make some changes in order to go past 3 missions a month and really dive deep into providing service to our community.
Thank you for that. Does it, Dr. Williams, Dr. Mukhtar, do you have anything to add to that question?
As usual, I agree with everything Dr. Waxman said, and to sort of follow up on what he was saying as far as the work we're doing with Sabrina and others at the School of Public Health. Learning from patients directly has been very illuminating. There's a professional call center at the School of Public Health that specializes in difficult to reach populations, and we've been calling folks who no show as part of our study, and it's amazing the kind of reactions you get. Why people stop coming to appointments and what barriers the care they face. It's not always as simple as I didn't have a ride. It could be like, I didn't like my wait time that day, so I'm not coming back. So it really forces us to step back and get creative as far as thinking about tackling these obstacles, because it's an uphill challenge, and we'll take them one at a time, but it keeps forcing us to be creative.
Yeah, the one thing I want to add is, this isn't, something that, for example, the provider can provide in the 15 minutes that he or she is seeing the patient. I think what's really important and what we're trying to build is building kind of a multidisciplinary approach to approaching access to care. And I think Dana and Katie are excellent additions to our team, and you've already seen how much of an impact they're already making. So I think the future is bright in terms of how we are going to start to listen to our patients in a way that we can make effective change, right? We're all well-meaning, we want to do this, but sometimes we're limited by the time. I wish there was more time in the day for us to do everything that we want to do.
Well, that's kind of related to the next question, Dr. Williams. You talked about there being a lot of reasons that there's, lost follow-up care. And so the next question is, and this might be a little bit broad of a question. How do you shift communities from being communities that have a lot of barriers to care to being communities that are a little bit more equal in all of its residents, getting the access that they need?
Yeah, that's a tough question. I think it's a combination of factors. The advocacy arm of trying to make sure we're engaging with these communities, understanding their needs, and helping get resources to people. And not all of that's solved by one ophthalmology department. I think that takes a lot of collaboration with local nonprofit and government sources to help bring that together. But really, the first step is talking to people, meeting people ideally where they are, and having that conversation, or engaging with folks who do come to our eye center, understand the needs of their communities, and thinking how we can really help. And I've learned a lot from the Mission of Mercy and Guerilla Eye Service about where people are coming from and what their needs are just by engaging directly with them. So it's a big problem to tackle. I feel like there's often, health disparities based on geographic areas and community-specific needs, but learning from those communities and advocating with other organizations can help to move the needle just a little bit to help improve these communities one bit at a time, both for healthcare access, but also kind of for needs in general. I think our perspective is perhaps helpful with that, getting folks what they need for their health.
So an interesting question is, are there any ways that people in the community can help work with the department and volunteer and, kind of contribute to these efforts?
Yeah, I love that question. I love the enthusiasm and all hands on deck for a problem like this, for sure. And I know, thinking, most directly, big screening events like the Mission of Mercy and these sort of follow-on activities we're planning to grow from that, as far as these large vision screenings, volunteers of all stripes are needed to make these things run. So even, over the course of Mission of Mercy, it's a huge stadium, and how to have wayfinders to help folks get from one station to the next and make sure no one's lost in the shuffle. Those volunteers go a long way. And there's volunteers kind of top to bottom, who help prepare the lunch for volunteers and help make everything run. There's so much more to it than just the sort of the physician-patient interaction. There's the infrastructure to make a big project like that take off, it takes a lot of hands on deck, and it takes enthusiasm, not necessarily medical training, but enthusiasm to help others. And I'm sure others may talk about how this could help with other initiatives too, but that's the one that first comes to mind.
Andrew's right on target in everything he said. And this weekend, we're going to be doing a glaucoma and diabetic retinopathy screening in Uptown for the first time. And I'm concerned that the people who most need to reach us won't necessarily be able to get there. And so what I'd like to plan in the future is to get them transportation. And that's not going to be Access, and it's not going to be Uber. I need people to act as jitneys, to pick people up at their homes and bring them to the screening event. That's something we very much want to do in some of these future events.
And just to add on to that, it's important for our community members to partner with us, right? You know, people in your community are going to trust people from the community. So it's important, you know, we would love to have community members be community health workers and help us better understand in the specific zip code that you're in, what your needs are, so we can better target those, if that makes sense too.
And one thing I'll say is we've received a lot of support from the Eye Near Foundation to make these initiatives work, and things aren't free. And so financial support for things like just the stands for phoropters or glasses checking equipment to go on, and all the sort of baseline equipment to make large scale vision initiatives work, financial support goes a long way to make that grow, especially as we keep growing initiatives. Our Mission and Mercy initiative from a year ago was smaller, and then just this year it grew, and we had to get more equipment and more people came, and everything's growing and scaling up, which is wonderful. And financial help has gone a long way with great support from the Eye Near Foundation.
Thank you. So these problems that we're seeing with barriers to access to care, is this a unique problem to the United States, or maybe you can expand on that a little bit?
Well, it's a complicated question, and barriers to care are faced worldwide and for different reasons. The United States has its own challenges with the insurance system, and sort of access to insurance coverage is not universally equitable, and there's disparities related to those issues that may not be as apparent in other systems. But no system's perfect, of course, and publications on this topic are present from across the globe, and so it's a sticky and challenging problem, and individual circumstances play a big role in understanding unique barriers to care for different populations, which I think is why it's so important to really dig deep and understand the communities we serve, because these barriers to care are unique to the communities and to individual patients.
Interesting thing about that, it's not the case that New Mexico is another country, but it's a different environment for healthcare. And Dr. Williams and Dr. Mukhtar both had the opportunity to spend a couple of months providing eye care in Albuquerque, New Mexico. And they've seen that, for the most part, the University of New Mexico has no trouble bringing a patient without funding into the offices. That doesn't mean that the barriers to care don't exist. There are still plenty of people who experience natural history disease, who go on to experience loss of vision from things we could have saved if we'd been able to reach them where they live, if we provided, as some others have mentioned in the Q&A, the education and awareness necessary. Transportation, and again, I'll bring up the cultural trust issues. The equivalent of Guerilla Eye Service out in Albuquerque was a project originally created by Dr. Linda Rose, where she took the medical students out to the Native American reservation, where, again, we have a very different set of barriers to care than we have here in Pittsburgh.
I think we have a question for Dana here. Is it possible to work with the patient navigator if you are a patient at one of our satellite clinics like Monroeville or Wexford, Bethel Park, etc.?
Oh, absolutely, yes. So I do get referrals from all the satellite offices. At times I will, if needed, I'll go to that particular office and meet with the patient. But yes, I'm mostly stationed here in Oakland, but I do branch out to whatever location I'm needed at.
And as usual, Dana's incredible, and it's sort of an example of this. That I've had patients who've had multiple needs and needed assistance with forms, and she would see that the patient has an upcoming appointment with me in Shadyside or a different location than she's normally based. So I'll come in, and Dana will be there because she's ready to have that patient come in, and she has their forms to fill out with them, and really meet patients where they are to expand the reach. It's not just at the hub; it's really all the center locations.
Thank you.
How do the demographics of our region here in Southwest Pennsylvania impact some of the studies that you're doing into this work?
I think it speaks to every community is unique, and compared to other works, each area has its own challenges. So I have a collaborator who is working with me on diabetic teleretinal imaging, so patients with diabetes having a fundus photo taking and then following up. Dr. Waxman leads a very similar program here at the University of Pittsburgh, and looking at sort of follow-up disparities and barriers between the Houston, Texas group and the University of Pittsburgh group. There are big demographic differences with language barriers, more so in the Houston area than here. But the transportation seems to be a little stickier in an area like southwestern Pennsylvania, where the public transportation options, especially further out from the city, may not be as reliable or as consistent as perhaps a more urban, larger city in Texas. It was just sort of interesting as we're exploring zip codes and follow-through rates and other issues. It definitely is a community by community issue, understanding unique barriers to care and really thinking about unique community, individualized driven solutions for these folks, really working with the community about their individual needs and finding solutions together. So every place is really different, I'm learning.
Thanks, Dr. Williams. Next question, maybe Katie would be a good person to answer this. For the GES program, what would it take to have more missions? Is it a matter of more funding, more awareness in the communities, more time, a combination of all those things? And additionally, I'd like to add to that question, if maybe you could just touch base on, how people find out about the missions that you're doing, so that they can spread the news and spread the word that there's going to be these commissions in their community to their neighbors, their family, their friends, etc.
Yeah, definitely. I think, like you said, it's definitely a combination of all of those things that would allow us to expand. As Dr. Waxman mentioned, we have maybe 5 events coming up in December, and that's an example of how we're expanding already. There's a lot of interest, a lot of buy-in from medical students. There's never really a shortage of that. But when we want to expand maybe outside of weekends or outside of weeknights, it does get tough because, like Dr. Waxman mentioned, it's hard to get residents and attendings who have the time and just, availability to attend those events. And to provide that comprehensive, front to back eye care that we want to do, we do need residents and attendings. And as far as how people find out about the missions, that's the main reason that we partner with primary care clinics, community-based organizations, because they have patients that they've identified who are at highest need for the care that we're providing. So they're really the ones who kind of advertise to their patient population, advertise to the communities. And one thing that's exciting is, I only started a few months ago, but I've already gotten to see the way that we're building partnerships with new organizations. For example, Second Avenue Commons is a shelter that's opening up kind of as we speak. It's in the process of opening, and they have a clinic on site. And so starting in January, I'm really excited to have our GES go there and potentially be there even once a month to reach kind of a different population, people who are experiencing homelessness in the Pittsburgh area. It's a great opportunity to serve that community and a great opportunity for students to interact with people that they might not otherwise get the option to.
Yeah, thank you very much for expanding on that. Do you work specifically, or how much do you work specifically with the homeless population in the Pittsburgh region?
Craig, the majority of folks we take care of for GES would probably be best characterized as working poor, and not the homeless population. There is some street medicine going on in Pittsburgh, and Dr. Jim Miller's been doing that. Dr. James Withers has been doing that. And we haven't to date gotten very, very involved. We collaborated with them to the point where if they see somebody who needs more than glasses, that they have, leave to send somebody to us. But we just got notice that we'll have a mobile eye van. And it's our intention to take the mobile eye van out to do street medicine with Dr. Withers and Dr. Miller, so that we can work with them side by side to take care of folks who just aren't going to come to one of our primary care sites. The van is being granted to us by the Brothers Foundation, extraordinarily generous donation to our program, and we're going to be able to use it for the homeless population to do street medicine. We'll also take it out to GES sites, potential GES sites where we might not have the room to set up. The Second Avenue Commons shelter is another good example where the van is probably going to make a huge difference.
Thank you very much. So I know Dr. Mukhtar, you had mentioned like community health workers. So this next question, I think, there is some work going on in the department. So maybe you guys can all expand upon it a little bit. The question is there anything that you're learning or doing that can help spread knowledge of vision loss prevention in these communities so that patients aren't only reached when they're already experiencing a problem?
That's a great question. I'll start off on it, and then hopefully others can chime in with their research in that area. So one of the things that, as we talk to other organizations in the community, is they've been really looking at community health workers. And so where does that come from, right? That's partnering with local churches or schools, things like that and we train them. So there is a community health worker program where you can get a certificate after doing a certain amount of training. Dana and I looked at that a few months ago, and then you're a certified community health worker. And then that way, you have trust in the community, and it's kind of your way to give back, right? To be able to educate people you're going to church with, or people you see at, a local organization that you're there every week or every couple of weeks. And that's how we're going to get that preventative education at a smaller level. And then hopefully from that data, we can then advocate for larger policies, is how I envision it in the future.
Thank you very much for expanding on that. And we have a question here, and I think we'll probably end with this question. It's asking about, working with neighborhood organizations, but I'd like to kind of point that direction to a specific organization. Dr. Waxman, you mentioned the mobile eye van that the department is receiving. Vision to Learn is an organization that's already doing this work in the Pittsburgh community and in other areas. Can you talk a little bit about the partnership that the department has working with the Vision to Learn folks?
Vision to Learn is an incredible organization, and they've been in the biz of getting glasses to kids in need for a long time. Their model is they'll bring their vans out to schools and examine the kids in the van, and get them their glasses for free. It's absolutely incredible. And they were a great partner at the Mission of Mercy event. They fielded 2 pediatric eye exam vans to the Mission of Mercy, and I think we ended up seeing about 40 kids over the course of 2 days, with the help of the Mission Mercy equipment and some of our community-based and department pediatric ophthalmology attendings. We want to do a next step sort of thing with Vision to Learn and UPMC Children's Hospital Care Mobile. We want to go to the middle schools of underserved communities, and we want to not just do one exam lane in a van, but work with Vision to Learn to set up 4 or 5 refraction lanes in a gymnasium. And we want to work with the folks at the school and particularly work with the kids to help us get their adult family members with eye care needs into the school for us to examine as well. We want to get them their glasses. We want to get them the appointments they need. And then what we want to do is, and I just had a chat this morning with the dean of the School of Education at Pitt. What we want to do is work in these communities to get the middle schoolers to understand that careers in healthcare are not out of reach for them. So, Craig, you're right on target. This is an example of where the School of Education, the School of Public Health, the Children's Care Mobile, Vision to Learn, Brothers, and of course, the Department of Ophthalmology at UPMC Eye Center are all coming together to get people what they need.
Thanks, Jake. Yeah, and I think it's just a really exciting time. As you mentioned, there's a lot of collaboration between the department and a lot of these community organizations. And with that, I'll put a little plug in. Our presenters here today and other faculty and staff and medical students from the Department of Ophthalmology will, of course, be at the Mission of Mercy event again this year. We also work with the Department of Otolaryngology to provide hearing screenings and hearing aid fittings and services at that Mission of Mercy event. And that event is scheduled for June 23rd and 24th this year, just to put something on your calendar so that you have those dates. And we look forward to working with both departments on putting together another great event with the Mission of Mercy folk and being able to help out a really large number of people in just a 2-day event, and really to make that dramatic impact all at once while we're also doing this mission work out in the community. So I want to thank all of you for joining us today. I'll put a plug in that we have one more webinar before we take a break for the holiday season until after the new year. In 2 weeks on December 14th, we'll be joined by Dr. Stinnett from the UPMC Voice Center, who will do a presentation on dysphagia. But for today, I want to thank all of our presenters for being here, and I want to thank all of our audience members for joining us for your lunchtime hour and learning a little bit more about the Access to Care initiatives that we have going on in the Department of Ophthalmology. So thank you all.